Great. We'll just give people another minute or so just to make sure we get everybody through. And then folks, what I'll do, speakers, is I'll turn my camera off, but then hopefully you'll be sticking to time. But if not, as it comes to time, I'll turn my camera back on. So when I reappear, if you haven't come to the end or if you're not on your last slide, you need to get to your last slide. And then there'll be time for questions, which I'll either read out or hopefully ask the speakers to come on screen so they can ask their questions. Okay, folks, I think we're pretty much ready to start. So welcome to the Grand Rounds. My name's Sadaf Faruqi. Good to see everybody, or at least to know that you're there. We're looking forward to two exciting presentations today. And to start with, we're going to hear from Dr. David Hall on behalf of Dr. Elena Zambon in cardiovascular medicine. David, over to you.
Hi, I'm David. I'm on the cardiology ST3s. We're going to present some work that I've been doing with the heart failure consultant, Dr. Zambon, and also Ishran, one of the other registrars, and a few other members of the heart failure team. It's slightly early what we've done at the moment, but basically we're trying to sort of design potential guidelines for use mainly by the acute medics, although also for the cardiology colleagues, for use for managing inpatients who come in with decompensated heart failure. These are sort of very focused guidelines aimed to sort of troubleshoot what we feel are possibly the main hurdles and the main problems that we're seeing, rather than the sort of general guidelines covering every aspect. So what we've sort of done, and I'll move on to in the next slides, is my colleague Ishran mainly has used the list from that the heart failure nurses collect, because they record all people admitted with decompensated heart failure to the hospital, and has used that to sort of collate data on how we're doing at the moment to sort of serve as a QIP like starting point to say, you know, and justify us making the guidelines and what we're focusing on, and see what we're doing well and see where maybe there's a degree of improvement that we can have. And then in the second half, I'll sort of go over the sort of the guidelines we have so far. Obviously, heart failure is incredibly common, as I'm sure all the medics have experience with. A lot of patients with primarily cardiovascular problems don't make it to a cardiology ward, which the data I'll show you in a bit supports, and the medical team end up dealing with a lot of heart failure patients. And although they're very good at it because they're very experienced, you know, in the last few years there has been some changes, and it is hard for a generalist or someone who specializes in another specialty to sort of keep up. So that's the sort of thing that our guidelines are aimed at addressing. So without further ado, so we've only looked at 32 patients so far, but we tried to look at them in depth, and that covers almost all the patients who were in November 2021 with a diagnosis made by the home team of decompensated heart failure. We kind of, as a team, felt that the sort of key things we wanted to look at was firstly length of stay, which I'll get to why we're focusing that in a bit. Secondly, were daily weights being performed? Secondly, the diuretic therapy. Obviously, almost all these patients did receive IV diuretics. Were they adjusted based on their response? Because we didn't want people who were maybe initially given the diuretics and maybe had the daily weights done, but there was no sort of correlation between those things, so the weights weren't being used to adjust the response. You know, it's not always possible, but ideally we do like these patients to be seen by the heart failure nurses or the cardiology team. So were these people actually seen by one of the members of the team during the admission? For the heart failure with reduced ejection fraction, because remember, this is all decompensated heart failure, you know, including valvular heart failure moderately reduced ejection fraction, heart failure preserved ejection fraction. So that, as most people are aware, the medications for heart failure are mainly licensed for less than 40% ejection fraction, but you can get people with more than 40% who can still come in with decompensated heart failure. So for that subset of patients, were they established on prognostic medication during their stay? Then another thing we're quite big on, which again, maybe general medics aren't quite aware of how big we are on it, and maybe the evidence base is hematinics and IV iron. And was that given if appropriate? And then in terms of discharge, as I'm sure most people are aware, it is very useful to have a dry weight. So if they come back in, you sort of have a target to aim for. So was this documented on the discharge summary? And again, we're not saying all these patients need cardiology follow-up, but was cardiology follow-up arranged at the time of discharge? Now, I'll freely admit these are very broad, blunt measures, and by no means saying that the target for these things should be 100%. For some of them, certainly. So, as I said, with cardiology follow-up, just because cardiology follow-up wasn't arranged doesn't mean that was inappropriate, and that's something we need to improve. But as I'll get into, we can maybe sort of get hints that maybe we can do a bit better there. Similarly, prognostic heart failure medication, what we try not to do into is we try to say whether they did it or not, mostly. And when I say in the things, was it appropriate or not, I'm talking against guideline thing, against strict guidelines. So for example, the prognostic medication, they may not be put on it because they have horrible CKD, or they develop an AKI, or they have some intolerance or something. So again, it's not necessarily a bad thing that they weren't got on the prognostic medication, but as I'll get into, you can maybe see that we could be doing a little bit better. But I don't want anyone going away thinking, well, I had good reason for not putting them in ACE. Why are they criticizing me? We're not. So just to move on to the first one. So the first one is just to show, quite surprisingly, of those 32, what the ejection fraction. So you'll notice that of the 32, only 9 of them had reduced ejection fraction. Now, to be fair, 5 of them didn't have a recent echocardiogram, and were all didn't have an echocardiogram during their inpatient stay and were sort of discharged for an echocardiogram. But it's interesting that heart failure with preserved ejection fraction, which includes diastolic heart failure, but also valvular heart failure, was actually 16, was actually half of them. For those who don't know, heart failure preserved ejection fraction, we normally talk about ejection fraction more than 50%, and heart failure reduced, as I said, is less than 40%, and heart failure mid-range is 40 to 50, which is kind of among cardiologists seen as almost like an overlap of the two phenotypes, where it's got some elements of diastolic heart failure, but it's also got elements of classic heart failure reduced ejection fraction. So I just put the length of stay at the side. So average length of stay was 8.5 days with a range of 5 to 22 days. And as you can see, 7 of the patients made it to the cardiology ward. I think that's quite important because we use that to compare it to other wards, and everyone else was on some variation of a general medical ward. There was no one outlied to a surgical ward or anything weird like that. So it really is medicine on one side and sort of cardiology, so K3 and CCU on the other. The reason we're looking at length of stay is Dr. Zambon felt that one of the things that we quite like to do for patients who are in is try and get them on prognostic medication and maybe increase. We like to try and discharge people on all 4 of the prognostic medications if we can, but we understand that may potentially require them to be in for a bit longer. So if we're sort of using this as a starting point, and then when we look in the future that maybe the length of stay has gone up, we can maybe see if that's due to maybe people not being diuresed effectively, or whether that is actually because people are staying in for a few extra days to be established on prognostic medication. So we just thought that was good to see whether, because if our guidelines end up keeping people in twice as long, but we get people on a couple more drugs, we'd obviously have to weigh that, or whether that's actually the risk benefit there. But so at the moment, people are staying just over a week on average. As a point though, the average for people on the cardiology ward is just over 10 days. So obviously we may be getting the slightly sicker patients, but it does seem that the cardiology patients do stay in slightly longer than general medical ones. And they're probably, as I said, there could be a couple of reasons for that. So to just move on to data, I'm not going to spend a huge amount of time talking about each of these slides because it's self-explanatory, but 23 had daily weights performed, 9 did not. Diuretic therapy appropriately modified based on weight change. In 27 it happened, and 11 it didn't. The way we define this, and it can be difficult because you have to look at every day, but generally we'd say that we'd want to be aiming for them losing about 1 kilogram a day, or alternatively, if input output, if they were losing more than 1 litre a day, and if they weren't losing 1 kilogram a day, was it increased? We try to be fairly nice about it. So obviously, if someone didn't lose 1 kilogram and they didn't immediately have the diuretics increase, we wouldn't put that in the no column. But if people were persistently not losing weight and persistently documented as being sort of overloaded and we weren't changing that, we'd put that in no. Again, as I said, these are broad measures. Maybe the reason the diuretic wasn't increased was because of hypertension or some concern with the kidneys. It doesn't necessarily mean that it was entirely wrong, but at the very least it serves as a sort of baseline to see if when we do the guidelines and people use them, whether it changes anything. So were they reviewed by a cardiology team? 12 weren't reviewed, 11 were reviewed by a cardiologist only. Remember, those 7 of them were on a cardiology ward, so those are all included there, because obviously all of them were seen by a consultant cardiologist. So that's at least 4 that were seen by just a cardiologist in the outlying ward. 7 were seen by the heart failure nurses only, and 2 were seen by a cardiologist and the heart failure nurse. So this is our prognostic heart failure medication. Sorry, I've used 2 shades of green, but basically the left is on, if you're not seeing it well on your screen, the left is on admission, the right is on discharge. So you can see of the 32, generally patients going home on more than when they came in, with beta blockers being the most popular. That isn't too useful of a slide because a lot of these people, as I said, has heart failure with preserved ejection fraction. So if we look at the subtype of prognostic heart failure medication in people with ejection fraction less than 40%, where the medication is indicating you actually should be giving it, then I think this is far more useful. So you can see that beta blockers, probably because people are less concerned about them in terms of damaging the kidneys, every single one of the patients was on it and none of them were stopped. ACE inhibitors went up a bit, MRAs like spironolactone, there was no change, and SGLT2 inhibitors, you can see no one was on it on admission, and we managed to get half the patients on it roughly on discharge. So moving on to hematinics. So when I talk about hematinics, and say whether they're appropriate, I am kind of only looking at heart failure patients. So we all know that general medical patients, if you have someone with a horrible microcytic anemia, regardless of their ejection fraction, you should be checking the hematinics. But there are guidelines from the ESC, which I think a lot of medics aren't aware of, for checking hematinics in people with heart failure with reduced ejection fraction. And also they've expanded it in the new guidelines to heart failure with moderately reduced ejection fraction. So those are the ones I'm focusing on. So this is the 11 patients with either heart failure reduced ejection fraction or heart failure moderately reduced ejection fraction. And we had a look to see whether the hematinics were checked. The yes column includes people who had hematinics checked in the last year. So if you had hematinics checked 6 months ago, we don't think they should be checked again. But no, so 5 of the patients didn't have hematinics checked and hadn't had hematinics checked in the previous year. When people were found to meet the criteria for iron deficiency and heart failure, was IV iron given? So as you can see, there were 6 patients, and again, I'm sorry that I used 2 shades of green. In 2 of them, IV iron was appropriate and it was given, but 4 of them actually met the criteria of having IV iron and didn't have it given. Again, there may be reasons for that, like active infection or something like that. So I'm not saying all of these were necessarily wrong, but I think it does give an indication that possibly there is room for increasing that. And then moving on to the discharge, roughly half had dry weight documented a bit over and half didn't. And then was cardiology follow-up arranged? In 19 it was, 13 it wasn't. So in the next sort of slides, what I do is just for a few of the key metrics. Again, we are talking about very small numbers here, but I look at the patients who were on the cardiology ward and the general medical ward to look for sort of differences. And again, I'm not saying that we're necessarily doing it better, I am kind of implying that a little bit, but you would hope at least that someone in the cardiology ward would maybe have slightly better treatment for heart failure than general medical ward, because obviously that's what they pay us for. So I use that to sort of compare and see if there's any sort of differences. So if we look at the hematinics, so again, this is for people with heart failure, reduced ejection fraction, heart failure, moderate reduced ejection fraction. Only 4 patients, again, we are talking about very small numbers, fit that criteria on the cardiology ward. And all of them on the cardiology ward had the hematinics checked. And on the medical ward, 2 of the 5 who fit the criteria had the hematinics checked. So basically all the patients who probably should have had the hematinics checked but didn't were on the medical ward there. And then giving IV iron in the appropriate patients, there was 3 on each, and on the cardiology ward, we apparently missed 1. We gave IV iron to 2 patients who should have had it, but 1 patient we didn't. And on the medical ward, again, we only talked about 3 patients, but we didn't. IV iron wasn't given, despite, as I said, being appropriate as per they met the guidelines. I'm not saying they didn't have an infection or another reason. You may also note that 4 of the 7 patients with heart failure reduced ejection fraction won the cardiology ward, which I think hints that we're maybe getting the the more classic heart failure and sicker patients possibly, which maybe is why patients in a bit longer, as I said. Then another iron is one thing where I feel like maybe some medical teams aren't quite aware of it, and the other thing is SGLT2 inhibitors, which are still fairly new, and although they're quite safe and there's only few cautions or contraindications, I think a lot of medics aren't too happy with prescribing them. I do apologise, it does half, so try to get rid of that. Obviously there's no such thing as half a patient, but for the patients who could potentially have had SGLT2 inhibitors initiated, on the cardiology ward, all 4 of the patients who should be on SGLT2 inhibitors were started on it during the admission. And on the medical wards, of the 5 people who could potentially have SGLT2 inhibitors, none of them had it initiated. So on that slide I showed you before, where 0 people on SGLT2 on admission and 4 on it on discharge, I think it was 5 actually. No, it was 4. All of them were on the cardiology ward. So this kind of hints that maybe the medical team aren't quite confident enough with giving it at the moment. And then in terms of dry weights, again, doing fairly well, but maybe the cardiology team are doing a little bit better at documenting it on the discharge summary, although in about half of them, the medical team are doing it fairly well as well. And then in follow-up, I thought I got rid of this, I do apologise. Cardiology, all of them were followed up, and the medical team, there was a few that weren't, and this is focusing on just patients with reduced ejection fraction, because I can understand maybe someone with heart failure and preserved ejection fraction, often they benefit less from a cardiology follow-up. But as you can see, pretty much all of these people are followed up, so this is quite reassuring. And this is for everyone. So it's the same thing for everyone. So I'll just move on to the guidelines. I'm not going to go through them in a huge amount of detail. I've only got a few minutes left. So the first thing to say, as I said at the beginning, these are just aimed at troubleshooting a few key things. ESC of the 2021 guidelines that go into a lot of detail. They're very easy to read. Anything where you need it more detail, you can go to there, and most of our recommendations are taken from there in any case. So if things aren't quite clear, that's the thing to go to. So this is kind of our little checklist or chart of the main things that should be done. Again, I'm not going to go through all of them. A lot of the things are the things I talked about, like people on prognostic medication or iron. We try to focus on things we sometimes see that miss, like looking for a trigger of the decompensation, like, this is done fairly well, arrhythmia and stuff like that. The key bloods we feel everyone should have. So again, focusing on the hematinics and stuff like that. The fact that we should focus on the diuretic response, trying to get people on appropriate dose of diuretics. I think there's a lot of variation, but generally they should be on at least 1 to 2 times their oral home dose IV generally. And then sort of during admission, making sure they're responding, getting on the meds, getting them reviewed, and then in terms of how to discharge them as well. So this is sort of a rough chart of how to give diuretic therapy be. So again, I'm not going to go through all of it, but the main thing is try to work out what the dry weight is, so you have a target, start them on a reasonable saline dose, and just recheck it every day. And down here is the sort of things that cardiology team can add for people who aren't responding, who are quite sick, stuff that most people would be aware of, like dobutamine and CPAP and infusions and transfer to CCU. These are just a little overview of the prognostic medications. You know, most of people are aware of these. There's some little things that I thought might help, like a pleuronome we prefer for ischemic cardiomyopathy. SGLT2s, because we have a few big trials. We tend to use dapagliflozin. Empagliflozin has recently been approved by NICE for the same thing in the last few days, but DAPA has had the longest thing, so you can give that. Our main concerns these days are people with previous DKA and type 1 diabetes, people who have recurrent UTIs as well. We tend, or structural bladder issues, we tend to be cautious, but otherwise we start a lot of people on it and they rarely have issues. It can cause hypertension, but most people tolerate it. It doesn't really cause hypoglycemia. A lot of the initial concerns from the studies, like UTIs, like limb amputation, like AKI, subsequent studies have shown is not actually as bad as we thought. So it's a very safe drug to give. But obviously, get in touch if or talk to the pharmacist if people want to give it, but obviously don't have experience with it. And these, of course, example drugs. You can give any from these classes, but you want to try and get them on one of these 4 classes by discharge, you know, unless you have a good reason not to. Entresto has to be initiated by a specialist, but is another one of these drugs that maybe is fairly new. So it's, for those who don't know, it's like a super ACE inhibitor. So you give it instead of an ACE inhibitor. It's very effective. The Paradigm HF trial has shown that it's better than ACE inhibitors, and patients often feel better on it as well. Reduces mortality, makes people feel better, but it does have all the side effects and excess as well. So renal dysfunction, symptomatic hypertension, it can cause in spades. So a lot of times we establish people on ACE inhibitors to make sure they can tolerate an ACE inhibitor before giving them something that could potentially make them really unwell, and then switch them over. So this is kind of telling you how to do that. But potentially there is an option for maybe younger, fitter patients with good kidneys and good blood pressure for starting people on it initially, but obviously after talking to the heart failure team. So this is a sort of chart more to make people aware that this is an option to discuss, rather than something we expect to be followed verbatim. And it probably will be changed finally, but it's a good medication, and we thought we should write just a little bit about it in the guidelines. Iron, so this is a key one, because we have no issue with people giving IV iron on their own. You know, it's very safe. IV iron has multiple studies and meta-analyses showing that it is very beneficial in IV heart failure, in decompensated heart failure. We treat it as a condition a bit like CKD, in terms of, rather than the BSG ferritin iron deficiency guidelines of ferritin less than 50, we sort of use a higher ferritin to represent iron deficiency. So the key numbers we look for are ferritin less than 100, or ferritin between 100 and 299, and transferrin saturations less than 20. And if you meet either of those criteria, you're classified as being iron deficient, and there is good evidence that these people feel better, their NYHA class goes down, their 6-minute walk improves, they're less likely to come into hospital, it possibly even reduces mortality as well. We have trials showing that it is safe for giving in decompensated heart failure as well, so you don't have to worry that it was only tested in stable patients. There's also, I think, a firm AHF trial which was testing less than 50%, but which shows it has some benefit in them as well. So you can actually give it to people with heart failure and moderate reduced ejection fraction as well. The other important thing is to say, in the FAIR-HF trial subgroup analysis, it doesn't matter if they're anemic or not, they get the same benefit. So this is the key thing I think people are missing. If someone's got a hemoglobin of 140, and heart failure, especially with reduced ejection fraction, and they meet these criteria of ferritin and stuff, you should still give them IV iron. The only reason I put less than 150 there is it's in the 2016 guidelines, and most of the studies didn't give it in people with AHB of more than 150. So there isn't really the safety data there. But if the AHB is less than 150, we should be checking the hematinics and ideally giving it. There was the iron out trial in heart failure patients that shows oral iron isn't effective because it's an inflammatory state. You just don't absorb it. They have minimal increase in their ferritin transferrin saturations. Their septin levels increase. They get reduced absorption, and they don't get any sort of clinical benefits with regards to the NYHA or the 6-minute walk or patient-reported questionnaires. So the evidence is very stark. IV iron makes them much better in any category you can measure. Oral iron doesn't. I'm not going to go through this, but this is basically a little cheat sheet. I often get calls from juniors asking how to arrange follow-up, or what's the best people to talk to, or when to get heart failure nurses as cardiology registrar. This kind of goes through it. And this is something the heart failure team wanted me to include. It's just their flow chart for how they sort of monitor people in hospital and arrange follow-up, sort of give people an indication of how the team work. And that's it. Going forward, we obviously intend to get the rest of the data for November. We still need to get these guidelines very early. We need, if we're going to get them actually approved, we need to run them by management, and obviously we need to talk to acute medics and see if they're happy with them, or if they feel we're missing stuff, or if they don't feel they would be useful. And yeah, I think that's my piece.
Okay, thank you very much, David. Elena, before we go into questions, did you want to add anything?
No, David did a great presentation. That those were the important topics, as he said.
Okay.
Part of the data not is just representing what is happening. Yeah.
Okay, great. So we have a couple of questions. Andy Fry, Andy, do you want to ask your question directly?
I can do, yep.
Yeah,
So was there a shorter length of stay in patients who are under non-cardiological specialities?
Yes.
And did you look at see whether the patients were being brought back to ambulatory care?
We looked if the follow-up was arranged, but we didn't specifically look at if they were brought back to ambulatory care. It's a good point. It's something we could look at. I do feel the medical team are more do that more often than the cardiology team. Is that what you're getting at?
Yeah, I think that's something we would try and use a lot. To shorten length of stay, but make sure we're seeing them a few days after discharge to check bloods, check diuretic doses, and start any medications that haven't been added in yet.
Yeah,
and often we work with the heart failure nurses there as well. So
yeah, the length of stay, the one I don't think is a particularly good quality metric. As I said, 8 days was the average, but it was 10.5 days for the cardiology ward. So for the medical wards, just off the top of my head, it'd probably be about 7 days, isn't it? Because we'd be dragging the average up slightly there.
Okay, great. Can I ask you about the SGLT2 inhibitors? Which group of patients should be on them? How do they work? And how would you start the medication?
So the patients who should be on them is everyone with an ejection fraction less than 40%. So it's basically the same indication as the other 4 medications. The contraindications I already went through, mainly previous DKA, because it can precipitate euglycemic ketoacidosis. So those are the main people who shouldn't be on it.
And how do they work?
How do they work? No, that's a very good question. So they promote excretion of glucose in the urine, which has a diuretic effect, but that doesn't explain the benefits we're seeing. There was a paper on my iPad with the 17 proposed mechanisms of why they work. So it's something where I was reading it one night and I got a bit tired. They're complex, basically, okay. And the proposed mechanism.
To read a bit more about them than that paper. They're a fascinating group of drugs. What about substrate utilization by the heart?
I don't know. I'm afraid. I apologize.
Elena, any evidence on that? Substrate utilization by the heart.
Oh, that's
they're drugs for diabetes, so they appear to be remarkably effective in heart failure. And as I think David was saying, it's not just about peeing out loads of fluid with your glucose, but any effects directly on the heart?
I'm not sure. I have to admit. Yeah, I don't think there's much data about it, but
yeah, I think people are looking into that. If they affect the fuel that the heart uses, basically.
Yeah.
Okay, we have a couple other questions. John, first, do you want to ask your question?
Well, I can do. It's really a matter of polypharmacy, in that clearly as more and more drugs are sort of introduced, often with great enthusiasm, then the numbers of drugs that this frail and elderly patient group are subjected to is increases. And my impression from the medical take is that often this can lead to problems. So I'd like just to comment on issues of polypharmacy in heart failure.
I mean, I think that's, as I've said repeatedly, the fact that these patients aren't on prognostic medications isn't marked as itself as a failing. For example, just as I said, I wasn't the person who collected the data, but I obviously reviewed it for producing the presentation. The medical team, there was quite a few patients who came in on ACE inhibitors and then had them stopped. I think it's fairly easy to see without looking at the case that that's been done because the patient has an AKI or hypertension or something like that. So, you know.
I guess Dr. First pointing out that, you have the ideal list of medications, but obviously one has to think about the patient in front, and obviously quite often if they're elderly and frail, as you've said already, it may not be possible.
No, I agree. I mean, I think if you look at the SGLT2 inhibitors and see that every single one of them was started on the cardiology ward and none was starting on the medical ward, I don't think it's an unreasonable hypothesis that could partly be lack of familiarity rather than every single cardiology patient was appropriate and every single medical patient wasn't appropriate. So you have to interpret it with a little bit of reserve. I don't think you can say that. Yeah.
And I think the idea is also for the guidelines to try to give the input, and in theory to try to start all the 4 pillars, they're called, of the prognostic drugs as inpatients, and that's why to see if the patients tolerate them. In theory, they should be stable for 48 hours on the drugs before discharge. Of course, that will lengthen the length of stay a lot. But on the other hand, being all the 4 medications, it reduces the hospitalizations. So it can have, a couple of days longer if the patients can tolerate all those tablets. Is probably worth in the long term. But of course, if they're like 90 years old, the prognostic importance is a bit less relevant than for a 70 years old.
Okay. Sorry, John. No, okay. Just one quick question, then we're going to need to move on to the second case. Has anyone looked at IV iron in people with normal ferritin or transferrin saturations?
When you say normal, as in more than a ferritin of 300?
Yeah, sorry, that's exactly what I meant. I just wondered if anyone's looked at people with HFrEF with actually normal ferritin and normal transferrin saturation, just to see if it also works.
I'm not familiar with any study that's done that. I did do a presentation this last year, and I did have a look, and I don't remember seeing that. The 300, the figures I gave seem to be picked slightly arbitrarily. I don't remember seeing any study where it was actually validated. As a cardiology registrar as well, I wonder if you. Is this a rhetorical question? Are you aware of a study?
I was
I
think it's just interesting that it works in people with normal, without anemia. And I wondered if it works through some alternative pathway which has nothing to do with ferritin and transferrin. So I was just honestly asking you.
No, I don't think so, because I have looked and I don't think so.
Thanks.
Okay, great. We're going to have to wrap it up there because we're eating into the time of the second case. Thank you both very much. There are a couple more questions in the chat. If you could have a look and maybe reply to them.
Yeah,
and people can see there's a couple about cardiac rehabilitation. Okay, so on to the second case, and we're going to hear from Dr. Rochelle Sriranjan on behalf of Joseph Cherian. Over to you, Rochelle. Okay, have we got you, Rochelle?
Unmute, yeah. Hi, everyone. My name is Rochelle. I'm one of the cardiology research registrars. Today, I'm going to talk about snuffing the flame in vascular inflammation, specifically looking at moderating vascular inflammation in the context of atherosclerosis and cardiovascular disease. Right, so where are we at in terms of CVD today? So given advances in invasive techniques, stent technology and pharmacological interventions, we have got better at treating CVD. Specifically with respect to MIs, over the last 2 decades, we've reduced mortality by about 20%, with up to 94% of people who suffer with MIs being alive at 1 year. However, hand in hand with this, the prevalence of heart failure is increasing. And CVD still remains the biggest cause of mortality and morbidity globally, accounting for up to 32% of adult deaths. Of these, 85% are due to MIs. So it is clear, beyond targeting traditional risk factors, we do need to look further in terms of therapeutic targets to achieve better outcomes. I'm now going to play a clip from a BBC interview of one of our trial patients that hopefully highlights this.
Julian isn't the kind of person you'd expect to have a heart attack. A keen cyclist, healthy eating, doesn't smoke, in his early 50s. But last summer, out of the blue,
pretty normal day up until 4 o'clock, and I had this enormous pain in my chest, and it was vice-like. And I said to my wife, I feel really, really ill. So I went and lay down, and the pain just didn't go away.
At any point when you're kind of lying in bed in pain, did you think this might be a heart attack?
No, because I didn't think it would happen to me. I thought I was too young to have a heart attack. I thought I was fit and healthy. I'd had no underlying symptoms. The previous weekend I'd been out on a quite a long bike ride, so just acting as normal, and then like a bite out of the blue, you get that huge pain in your chest, and you find yourself in Papworth.
Right, okay, so this is this gentleman's angiogram. So on the right here is his blocked occluded left circumflex, so it's basically a stump, this blood vessel. And on the left-hand side here is his right coronary artery, and as you can see, he has about a mild to moderate lesion in the proximal part of this blood vessel. So this is his post-PCI picture. So we've opened up the blood vessel and restored flow. So let's look a little bit at this chap's risk profile. On the right-hand side here is his ECG, which is remarkably normal given he occluded his circ. So he's a relatively young gentleman, so 56-year-old, no underlying conditions at all, so no past medical history. In terms of risk factors, the only one he had was that his father had an MI in his 60s, but his father was a smoker. It's a very active gentleman. On admission, all his bloods, apart from the troponin, were actually normal, including the point of care CRP. His TROP, however, was around 24,000. And he went on to, I screened him as a part of kind of trying to recruit him for one of our trials, and his HSCRP, which is a high sensitivity CRP, was quite elevated, it was 46. So HSCRP is a well-validated marker of inflammation. So let's just talk a little bit about the role of inflammation in atherosclerosis. I think everybody knows that inflammation is implicated in kind of all stages of atherosclerosis, from initiation to progression to all its complications. The preclinical models have shown that MI can actually trigger an acute inflammatory response that can accelerate atherosclerosis, conferring a residual risk of fuse events, which is currently not targeted by therapy. So studies have also shown, these are clinical studies, that new myocardial ischemia and MIs can reoccur in up to 54% of patients in the first year after an MI. So this is a slightly, I do apologize, there's a bit of basic science in this presentation. I can't quite launch into targeting the immune system without talking about it a bit. So I'm just going to dwell on the headlines here. So the main kind of, in terms of the innate immune system, the main players are the macrophages and the neutrophils. So this gray cell here is a macrophage, and it is the most abundant leukocyte subset in atherosclerotic lesions. And in the presence of traditional risk factors, these macrophages are attracted to atherosclerotic plaque via integrins and chemokine receptors. And there's also an increase in the number of resident plaque-resident macrophages. The mechanism of that is unclear. And these macrophages basically can determine the inflammatory environment within the plaque. For example, cholesterol crystals can activate NLRP3 inflammasome, which basically cleaves this IL-1 beta to its active form, and this is a pro-inflammatory cytokine. So neutrophils are the next set of cells that are gaining kind of increasing traction as a target in atherosclerosis. And these are these yellow cells here. So neutrophils are the most abundant circulating white blood cells in humans. And that's been shown to localize to areas of plaque erosion. So plaque erosion is a precursor for adverse events such as arterial thrombosis. And these neutrophils basically secrete products through neutrophil extracellular traps called nets. And these nets can attract macrophages as well as activate them, for example, to produce inflammatory cytokines such as IL-1 beta. So preclinical studies have also shown that these nets can lead to thinning of the fibrous cap, which is a feature of high-risk plaque, basically. So far, in terms of therapy that successfully reduced cardiovascular outcomes in atherosclerosis, targeting inflammation, they've all basically targeted the innate immune system. I'm going to talk about these not in great detail, but they are quite interesting. So I will say a bit about them. So CANTOS was a landmark study which basically for the first time showed the clinical efficacy of targeting inflammation to reduce cardiovascular outcomes, adverse cardiovascular outcomes. So in this study, they recruited about 10,000 patients who had previous MIs and who had a persistently elevated hsCRP, and they gave them canakinumab with basically an IL-1 beta antibody. So basically blocks pro-inflammatory cytokine IL-1, also led to a reduction in IL-6, which is also pro-inflammatory. Now, at a median of 3.7 years follow-up, this trial showed that it reduced cardiovascular events, so non-fatal MI and stroke, as well as cardiovascular deaths. Now, this did come at a cost, so there was a small but significant increase in fatal infections. And when you compared all-cause mortality between the two groups, this wasn't different. So the other drug that's been kind of coming to the spotlight is low-dose colchicine. So colchicine is a tubulin disruptor which inhibits neutrophils. So the first trial to be done was Lodoco, which was actually quite a small trial. So it recruited about 500 patients, but was able to show, and was open labeled, was able to show that there was a significant reduction in ACS as well as cardiovascular death at a follow-up of 2 years. This was then followed up by Lodoco 2, which recruited about 5,000 patients, and it began as open label, and after a month, 30 days, they randomized patients to either colchicine or placebo. And this validated the results of the small study. Colclot is one that uses low-dose colchicine in patients who've had fresh, recent MIs. So they give colchicine within 30 days of the infarct. And this again has shown that it reduces non-fatal MIs and stroke, cardiovascular death, as well as hospitalization due to angina that required urgent revascularization. However, again, this trial showed that there was an increase in infections, namely pneumonia. Okay, so what about the adaptive immune system in atherosclerosis? So again, I'm not going to go through this in detail, just kind of the highlights. So adaptive immunity arises more slowly. It's more exquisite in its selectivity, and we're able to target a wide range of specific structures. So broadly speaking, there's antibody-mediated immunity through B cells and cellular-mediated immunity through the T cells. And thus far, we haven't actually been able to harness the adaptive immune system to modulate atherosclerosis. And our team basically focuses on the adaptive immune system for targeting atherosclerosis. So we aim to target T cell immunity through upregulating T regulatory cells. There are 2 trials with respect to this, LILACs, which is finished, and IVORY, which is ongoing. I'm going to talk about these 2 in detail in the following slides. We are also aiming to target B-cell mediated immunity through rituximab, which is an anti-CD20 antibody, which depletes B cells. And the idea is we limit myocardial injury and improve cardiac outcomes. That's a long-term goal. So we finished the phase 1 study for this, which is RITA-MI1, and RITA-MI2 is due to begin later this year. So my trial's IVORY, and I'm going to just focus mainly kind of on T regulatory cells in atherosclerosis and MI for the rest of the presentation. So T regulatory cells basically moderate immune activation, which is largely mediated by T effector cells and promote immune tolerance. So in the preclinical models of atherosclerosis, for example, depleting Tregs seems to accelerate atherosclerosis, whereas expanding Tregs seem to be atheroprotective. In the MI model of atheroma, in the MI model in preclinical mice, basically, Tregs are important in promoting myocardial healing and reduced adverse cardiac remodeling. So how about human observation studies? So what they've shown is that patients with MIs had lower numbers of circulating Tregs, and these had impaired function. Whereas expanding and activating pro-inflammatory T effectors were positively correlated with the occurrence of ischemic heart disease. So what we are trying to do is to modulate the immune system by increasing the number of T regulatory cells. And we're doing that by using a compound called low-dose interleukin-2. So IL-2, its current license use is in metastatic renal cell carcinoma, and they use quite high doses, around 18 million international units, given on 5 consecutive days, and these are repeated in cycles. So low-dose interleukin-2, and these, in various trials, they've used from 0.3 to 3, which we did as well. At this low dose, interleukin-2 will lead to an expansion of T regulatory cells. So why are we looking to repurpose drugs such as low-dose interleukin and rituximab? It's because it massively cuts down on the drug development timeline and cost, and this is something our group actively tries to do. So in terms of talking about low-dose interleukin-2, it's been used in other autoimmune conditions such as diabetes, SLE, rheumatological conditions with promising results. So these have been quite small studies, to be honest. The main adverse effects have been local injection site reactions and mild to moderate flu-like symptoms, which have all been self-limiting. So I'm going to talk a little bit about the 2 trials that we used low-dose interleukin-2 in to increase the Treg numbers and to modulate the immune system in atherosclerosis. So the first one was LILACs, and this was a randomized, double-blind, placebo-controlled dose escalation study. It's an adaptive trial. So for part 1, we basically recruited patients who had had previous MIs, so stable coronary artery disease. And in stages, we gave them different doses. So we started off with the lowest dose. So for example, 0.3 million international units. This was given consecutively for 5 days. During this period, we looked at how well it was tolerated, all the safety data. We did FACS analysis and looked at the biological efficacy of low-dose interleukin-2. Is it actually leading to an increase in T regulatory cells? So once the first group was finished, the second dose was decided on, so the dose for the second group, for example, and so on and so forth. And we tried 5 different doses, and depending on these, the results of these doses, we took 2 forward to part B. So part B was done in patients who presented with ACS, and we limited recruitment to patients who presented with STEMIs and unstable angina. So patients who had STEMIs were excluded. And we trialed, as I said before, 2 doses, so 1.5 and 2.5. And I'm going to talk about the results of this trial shortly. Before that, just a quick note on kind of oversight of these clinical trials of investigational medicinal products called CTEMs. In one word, it's vigorous. So there's a lot of effort that goes into kind of the running of the trial and analyzing the data even before you come to the end. So, for example, the sponsor, there's a trial sponsor who takes responsibility for the overall kind of running of the trial. Then CCTU, which is Cambridge Clinical Trials Unit, they monitor our trial. They also submitted all the ethical and regulatory documentation. So in terms of monitoring, they come around and they check, do we adhere to the protocol? Is the main tenets of is blinding maintained, basically? And so there's a lot of paperwork involved in all these, in doing this, basically. There's also more kind of groups involved in terms of mainly looking at the safety data. So there's a trial management group. So we meet regularly and we discuss blinded safety data and the progress of the trial. There's an independent data monitoring committee whose kind of primary aim is patient safety. So they meet at predefined intervals, quarterly or 6 monthly, to review the progress of the trial, and they get to see the unblinded safety data. Right, so going back to kind of the results. So these are the results of LILACs, and I've just put the results of part B, which is patients who kind of we dosed with low-dose IL-2 who had STEMIs and unstable angina. Overall, low-dose IL-2 was well tolerated in these patients with stable ischemic heart disease and ACS. The commonest side effects we saw, as in previous studies, were injection site reactions and kind of self-limiting flu-like syndrome. So these tended to kind of disappear on their own after a few days. In terms of kind of biological efficacy, so the results that are on this slide are FACS results, which is immunocell sorting essentially. So we look at FACS to see, are the number of what are the T cell subsets doing. So this graph over here basically looks at T regulatory cells, and we see the doses below. So essentially, with the treatment of low-dose IL-2, there's an increase in the number of T regulatory cells in a dose-dependent manner. Now, we also looked at the effect on the pro-inflammatory T effector cells. And what we didn't want is, obviously, you don't want pro-inflammatory cells increasing as well. So as you can see here, there was no significant increase in the T effector cells, which is what we wanted. So based on these results, we selected 1.5 as the dose to take forward to phase 2. Because we saw an increase of Tregs by up to 85%, 84% at this dose. Okay, so this is a very data-heavy slide, and I'm really going to skim through it. So we also did single cell sequencing in collaboration with Prof. Clatworthy's group, and this allowed us to do a detailed study of the distinct molecular pathways and cell-to-cell interactions that are either activated or inhibited by low-dose IL-2. So panel A shows single cell RNA sequencing result that demonstrated that with treatment of low-dose IL-2, we saw an enrichment of T regulatory cells and a decrease in CD4 positive T effector cells. Now, you can also see there are an increase in other T cell subsets. So we're looking at this more closely in other kind of experiments we're doing at the moment. But these are kind of some of the results. These results are interesting and surprising, actually. So the other B panel B is basically T cell receptor sequencing, which shows we're looking at clonal expansion here of T cells. So very, very briefly, so the red dots are basically the T regulator cells, and you can see with treatment with IL-2, you get clonal expansion of the Treg cells. So the blue dots are basically CD-positive non-Treg cells. And overall, if you compare to untreated, we're seeing a decrease in clonal expansion. Panel C is a gene set enrichment analysis, which basically shows that there's an increase in several genes related to the metabolism of Tregs, which is expected, but it just helps us dissect at a molecular level what's going on with IL-2 treatment. Okay, so I'm going to talk about Ivory now. So Ivory is using low-dose interleukin-2 to upregulate T regulator cells with the hope of reducing vascular inflammation in ACS patients. So we're going to measure vascular inflammation using FDG PET, and we're focusing this treatment on patients who have a raised hsCRP, because we hypothesize that these patients have an increased residual systemic inflammation and are at high risk of recurrent cardiovascular events. So the number we need for this trial is 60 patients. We're about halfway there now. Just a quick slide about FDG PET. So FDG PET is the most widely used radionucleotide in imaging vascular inflammation and atherosclerosis. Histological studies from arterial specimens have shown a very strong correlation between FDG uptake and inflammatory cells. Uptake has also been demonstrated in unstable and high-risk plaque. And FDG quantification is highly reliable and can be reproduced in large to medium-sized blood vessels. Both our group and other groups have used FDG in phase 2 clinical trials before. I'm not going to go through this in detail, but this is just an overview of what we're looking at in this trial. So apart from the primary endpoint, where we're looking for a change in vascular inflammation as measured by PET-CT before treatment and after treatment, we're also looking at how the T regulatory T cell subsets basically change with IL-2 treatment. So we will look at not only Treg cells, but other T cell subsets. And along with kind of looking at this, we will also continue to look at the safety and tolerability of extended dosing of low-dose IL-2. We're also doing echoes on this patient pre and post treatment, and we'll be measuring LV function as well as global longitudinal strain. We're banking serum to look at cardiac biomarkers and cytokines later on. We're also banking PBMCs to do a range of tests on data. So the overall trial design, so this is a phase 2 randomized double-blind placebo-controlled study. And I basically approach patients who I think are, eligible. Essentially, we have a long, detailed list of inclusion and exclusion criteria, which I'm not going to go through. And they get screened, and when they pass screening, they get randomized either to placebo or low-dose IL-2 in a 1-to-1 ratio. So most of our patients who fail screening do so because their hsCRP is usually normal. So once they get randomized, they then have their PET-CT scan. Then they have an 8-week period of dosing with low-dose interleukin-2, and then they have their follow-up scan. The overall demographic of the patients who we've recruited for this trial are basically the overwhelming majority were male, they were white, they were obese, and this trial had a younger cohort of patients than you'd normally expect for MI trials. So this goes into detail in terms of trial design per participant. And as you can see, there are 16 visits, which is, it's quite an intensive trial. I usually try and minimize their hospital visits, so try to screen them before they go home. So the first in-person visit is usually for the FDG PET scan. The dosing is basically divided into 2 phases. There's the induction phase, during which we give kind of a subcut injection, which is how low-dose interleukin-2 is given once a day for 5 consecutive days. And after that, you get 7 weekly doses. After last dose, within 1 week, we try and do the FDG PET CT scan. And then the last follow-up visit happens 4 weeks after their last dose. Given how intensive the trial is, I was quite surprised. So uptake has been fantastic. However, we have had challenges to recruitment in the form of other things, such as, for example, COVID. So Ivory actually opened just before the first wave of COVID. So we had to shut down before we recruited even a single patient. And we reopened after the first wave with quite a few changes to the protocol that specifically looked at kind of how we were going to mitigate the risk of COVID in our participants. So we said we were not going to recruit patients who were COVID positive at screening. We withdrew patients who became COVID positive during dosing. And we tried to make all non-essential visits remote, essentially. So the last follow-up will be done via telephone unless there are safety concerns and we want to bring them in. So after the first wave, just before the second wave hit, we opened the trial. However, we were limited to dosing 3 patients per week because our pharmacy had, they were understaffed and they had lots of pressures on them. So we were restricted, and this is a major bottleneck for us. Because the trial went on for quite some time, so 8 weeks. If we had 3 patients going, I couldn't recruit patients for another 8 weeks, basically. We then had another halt in recruitment because we had problems with sourcing the IMP. And the latest halt to recruitment has come in the form of the PET CT scanner being changed in Addenbrooke's, but hopefully we will restart recruitment in April.
We're running out of time now. We're going to need to just show the final slide if you can, please.
Yeah. So I'm just going to show a little video clip of our patient basically saying the utility of these clinical trials for the patient. Julian, just about to give your injection now, or the blood seems to be okay.
Okay. If this smaller trial is successful, the drug will need to be tested in large-scale human trials, but it could one day spare thousands of people the fear of having a second heart attack just a few months after the first.
The weeks after the attack, I just lost all confidence in my own body. I didn't want to do anything, and it's really building that confidence again in your own body, being able to go and do things that you love. And if there's a drug out there that can help people get back to normality, that's got to be hugely beneficial.
Richard Westcott, BBC News.
And that's it.
Okay,
thank you.
Great, thank you. So I'm afraid we've run out of time, so we won't have time for questions. I'm sure people can ask you questions directly, but I think a really nice example of experimental medicine, actually, and of clinical trials, and of how and insights from understanding the sort of basic mechanisms of disease can hopefully lead us to some new therapies. I've got many things I'd like to ask you, but I think we'll have to do that afterwards. We are out of time. So thank you very much. Thank you, Joseph, also. Great. And thank you, folks, for joining the grand round. Okay, bye.
Thank you very much. Bye.